Eating disorders have been documented for centuries. In fact, the first description of anorexia nervosa, or AN, was described by Sir William Gull in 1874. In his paper he published on AN, he reports 3 cases. In one of the cases, he reported a female named Miss A, who was 17 years old, 82 pounds, and 5 feet 5 inches. She was incredibly thin and refused almost all food. He recorded that she was frequently restless and active. He observed her from 1866 to 1868. In 1868, she seemed to have made a full recovery and weighed at 128 pounds. Some of the criteria for AN are engaging in persistent restriction of food leading to low body weight, intense fear of gaining weight or becoming fat even though the person is underweight, or they could have persistent behaviors that prevent weight gain even though he or she is at a significantly low weight, and disturbance in the way body weight or shape is experienced. There is a lack of recognition of the seriousness of the current low body weight. Another type of eating disorder is bulimia nervosa, or BN. It was first formally characterized by Gerald Russell. In 1979, he wrote a paper on bulimia nervosa. In this paper, he also described Russell's sign, which was named after him. Russell's sign is defined as calluses on knuckles or back of hand due to repeated self-induced vomiting over long periods of time. Russell's sign is usually found in individuals with bulimia nervosa or anorexia nervosa. 3 main criteria of BN are: 1. An individual who reports episodes of binge eating. Binge eating is eating a more than normal amount of food in a discrete period of time. 2. The individual engages in purging. This means he or she will do things in order to deplete binge eating effects. 3. Shape and weight is a big factor on how they judge themselves. In 1944, 36 conscious objectors enrolled in a study with extreme dietary restriction. This is known as the Minnesota Semi-Starvation Study. The government was interested in the effects of restricting intake of calories. They volunteered to live on a diet of 1,500 calories a day for 6 months. The results were not only weight loss, but there were a lot of psychological and social effects. Many tried to escape, and one guy even chopped off 3 of his fingers. In the last 8 weeks of the study, they had unrestricted access to food. They noticed behaviors like smuggling food, feeling pleasure of watching people who ate food, and an overall obsessive behavior with food. They had increased depression, difficulty concentrating, and no pleasure without food. Anorexia nervosa and bulimia nervosa aren't the only eating disorders. Some other ones are pica, rumination disorder, avoidant restrictive food intake disorder, or ARFID, binge eating disorder, other specified feeding or eating disorder, and unspecified feeding or eating disorder. Pica is an eating disorder that shows persistent eating of non-nutritive, non-food substances over a period of 1 month. Examples of non-nutritive, non-food substances shown are ice, feces, and metal. The eating behavior is not part of a culturally supported or socially normative practice. Someone who has rumination disorder shows repeated regurgitation of food over a period of 1 month. Regurgitated food includes re-chewed, re-swallowed, or food that is spit out. Avoidant restrictive food intake disorder is an eating or feeding disturbance displayed by persistent failure to meet appropriate nutritional and/or energy needs associated with one or more of the following: A. Significant weight loss or failure to achieve expected weight gain or faltering growth in children. B. Significant nutritional deficiency. C. Dependence on enteral feeding or oral nutritional supplements. D. Interference with psychosocial function. For example, a child with ARFID would have a hard time at a birthday party or eating lunch at school because of the food choices. Orthorexia is a disorder that deals with the obsessionality with clean or healthy food. The goal usually isn't thinness, but an elitist thought process. Individuals with orthorexia will spend an inordinate amount of time thinking about food and have excessive guilt/compensatory behavior if imperfect. The criteria for binge eating disorder includes recurrent episodes of binge eating and episodes that are associated with 3 or more of the following: eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of feeling embarrassed by how much one is eating, feeling disgusted with oneself, depressed, or very guilty afterwards. The binge eating occurs once a week for at least 1 month. Atypical AN, similar to anorexia nervosa, but individuals' weight is within or above normal limits. And purging disorder, recurrent purging behavior to influence weight or shape in the absence of binge eating. Unspecified feeding or eating disorder is a disorder that looks like an eating disorder but does not meet full criteria for any of the diagnostic classes. How do eating disorder specialists assess whether or not a patient has an eating disorder? There are eating disorder examinations, eating disorder inventory, which is a self-report questionnaire, binge rating form, and mood, trait, and affect questionnaires. They look at the history of the patient's eating patterns, body image concerns, and life events. They ask if they've had previous treatment for eating disorders or substance use and why they are seeking treatment. There are treatment options for individuals who struggle with eating disorders, and inpatient treatment focuses on medical and behavioral aspects for patients. It can include daily family therapy sessions and group and family meals. In a residential treatment, the patient stays 24/7 in a residential setting where the focus is on psychotherapy and skill building. 6 or 10 hour partial hospitalization, or PHP, is about 5 to 6 days per week. They supervise meals and snacks. They have multi-family meals, individual therapy, skill-based DBT groups, and monitoring of vitals. In intensive outpatient, 5-day or 3-day, usually helps patients transition back to school, activities, and jobs. You're probably wondering, what are the medical consequences of eating disorders? Every system in the body is affected by eating disorders. Malnutrition can cause amenorrhea, which is the loss of menstrual cycle, stomach pain, fatigue, cold intolerance, lightheadedness, signs of emotional or cognitive blunting. The cardiovascular system is affected. A low heart rate is less than 45 beats per minute, when a normal heart rate is 60 to 100 beats per minute. Individuals who have eating disorders sometimes exhibit this low heart rate. This increases the risk of cardiac arrest. This is the number one cause of death from eating disorders. There are also neuropsychiatric effects. Structural changes can be potentially irreversible. You start breaking down tissue when you lose energy, including in your brain. On the left is an image of a normal brain, and on the right is an image of a brain of someone who has anorexia nervosa. This leads to cognitive and psychiatric problems that lead to anxiety, depression, and suicide, which is the number 2 cause of death in eating disorders. Having an eating disorder can affect your reproductive system. In women, it can result in low estradiol, and in men, it could result in low testosterone. The effects depend on the stage of development. In women, there could be an absence of menstrual periods and infertility, and in men, there could be a decreased sex drive. Having an eating disorder can result in anemia and immune suppression. Immune suppression can lead to low white blood cells and poor wound healing. If one has an eating disorder that involves purging, it could result in dental erosion and oral abrasion. Some skin-related effects of eating disorders can include lanugo, dry skin, hair loss, and Russell sign. What are the effects of eating disorders on the brain? Interoceptive neural circuits sense physiological signals of basic survival needs, like energy or water, and influence the selection of the actions that result in the satisfaction of those needs. Food intake is obviously essential for survival, and the neural processes mediating hunger are under strong selective pressure. Individuals with eating disorders exhibit temperament and personality traits, which are related to neural circuit function and are important in the development and maintenance of the disorder. This neurobiologically based temperament is characterized by 1. Elevated anxiety or harm avoidance, 2. Altered reward sensitivity, 3. Altered cognitive flexibility/inhibition, 4. Altered interoceptive awareness. There are a few circuits in the brain that explain eating disorders. The reward circuit identifies and evaluates rewarding or emotionally significant stimuli and generates emotional response. The inhibitory control circuit supports cognitive control, behavioral inhibition, planning, and decision-making. The motion regulation circuits support upregulation and maintenance of positive emotion and downregulation of negative emotion. The salient circuit evaluates interoceptive cues like pain, taste, or fullness and integrates cues with motivational/emotional processes. It was found that women who recovered from anorexia do not engage reward circuits in the brain when hungry. However, healthy women without a history of an eating disorder show an increase in brain response and reward circuitry when hungry compared to when satiated. This decreased sensitivity to reward may explain why individuals with anorexia are able to ignore hunger-related urges and starve themselves. Women recovered from anorexia also showed increased activation of cognitive self-control circuits in the brain, perhaps making them more effective in controlling the urge to eat. All medical complications are reversible with weight restoration, except those that involve a critical window for growth and development. There are specific messages that reflect a culture's ideology and are conveyed by socialization agents that influence an individual's behavior. This focuses on social constructed variables, culture-specific and culturally determined norms and ideals, involvement of socialization and social cognitive learning, existence of within and across group differences based on exposure. There are a few different models that explain the social, cultural effects that lead to an eating disorder. The tripartite model shows the effects of peers, parents, and the media. Peers may tease or make comments on the appearance of the individual and start comparing. Parents can do the same, or it could be a family who endorses liking of thinness and dieting. The media can also have an influence if they are exposed to it a lot and start comparing themselves to figures in the media. This is where the main pressure to adapt to cultural ideals comes from. As a result, two psychological processes happen. 1. An individual internalizes these cultural ideals. 2. We start to compare our appearance. How we evaluate ourselves in terms of achieving that cultural ideal, the more we are likely to go down the pathway of extreme behavior. If the individual wants to make a change, he or she could start restricting and lose weight, binging and purging, and start having a drop in psychological function. The dual pathway model is similar, but it's essentially saying just being around the pressure to be thin can create body dissatisfaction without any internal psychological processes occurring. If they are internalized, then it is an extra risk factor of developing body dissatisfaction. The dual pathway model is very similar to the tripartite model in the way that once you start experiencing body dissatisfaction, it may lead to dieting and a bulimic pathology. The objectification theory focuses on how our culture sexually objectifies women and places women at risk to self-objectify. This could lead to body monitoring. That habit leads to negative experiences like body shaming and appearance anxiety, which could lead to disordered eating. In the biopsychosocial model for males, the sources of cultural messages are peers, parents, and the media. Main internal processes are drive for muscularity and body-focused anxiety. How much he is engaging in the concern over appearance determines whether or not he will experience body dissatisfaction and start binging, restricting, and having a drop in psychological functioning. I hope you learned something new about eating disorders, and that is the end.